Good evening, everyone. And in today's session, we are going to do a very important topic of option guide, and particularly of the obstetrics portion, that is postpartum hemorrhage, right? Which you commonly call as PPH. So, management and about knowing about PPH is of paramount importance because, as a general practitioner, also maybe you have to manage some cases of PPH as well, right? And it is easy topic but very high yield, be it to theory exams or NEET PG or INI. They can ask it everywhere, right? And knowing it is very easy. It's not a topic that you need a high level of understanding or somewhat like that to do, right? And for this topic I have referred the WHO guidelines, some WHO websites, as well as ACOG guidelines, right? So these are completely updated according to the recent guidelines. So starting off with postpartum hemorrhage. Uh, Postpartum hemorrhage, as you just can predict, right? If you don't know if it literally a word about PPH, then if you dissect the word, then it means that it will be an excessive hemorrhage, is excessive bleeding, right? So excessive bleeding postpartum, that is post delivery, right? So excessive bleeding post delivery, which can affect your vital organs, is basically what we call as postpartum hemorrhage, right? So we have some definitions which are very important to know. So let's start with the PowerPoint definition and classification of PPH. Don't worry, I will write everything. The PPT is just for your reference, right? So definition classification is the paramount importance here. So let us ignore it and we will write. Okay. So when I say that it is a PPH, okay, WHO and ACOG contradict in this place, right? So according to WHO, more than 500 ml of bleeding, right? More than 500 ml is what they say is PPH, right? Or in case of a cesarean section, 1000 ml, more than 1000 ml is PPH in case of C-section. And we commonly do lower segment cesarean section, we prefer it, right? More than 1000 ml. Or it can have a 1500 ml or excess bleeding in case of hysterectomy. Okay, so these are the general measurements of bleeding in case of postpartum hemorrhage, what we call as postpartum hemorrhage. I'm teaching first what we call as postpartum hemorrhage, and then we'll move to the section where we'll try to manage the PPH, right? So WHO definition is clear. ACOG definition contradicts it. ACOG contradicts the definition. I can say it doesn't contradict it, but it takes average. If you take the average 1500, 500, 1000, 2000, 2000 by 2, okay, roughly, you can take 1000 ml. Okay, so ACOG tells that more than 1000 ml of blood, irrespective of the cause of bleeding, is what we call as PPH. Okay, so PPH equal to more than 1000 ml bleeding, irrespective of cause. This is the ACOG definition of postpartum hemorrhage. Okay. If this is clear, we'll move to the risk factors. What are the risk factors due to which a hemorrhage can occur post delivery? Okay. Epidemiology and importance. So, postpartum hemorrhage stands as the leading cause of mortality among women, particularly maternal deaths in low to middle income countries, right? Uh, India comes here, right? So rapid recognition plus standardized protocol reduces the mortality. This story you all write in PSM exams. So we'll not go into that. So this is a graph. I don't know why I put. Okay, etiology. Let's first discuss what are the etiologies of this postpartum hemorrhage. So we have four T's which are very important according to the protocol. So we have something called 4T protocol. not protocol, I can say causes, basically causes. Okay. T, the first T is for tone. The first T is for tone. Okay. So this tone is responsible for the maximum cases of PPH. This is the most common. And this PPH is called as, I am sure you must have heard, atonic PPH. Atonic PPH or primary PPH. Okay. Atonic PPH or primary PPH. Second thing, second T, first T is gone, tone. Second T is trauma. Trauma. Any kind of perennial tears. I am sure you must have heard about the degrees of perennial tears, primary, secondary, tertiary, in which muscles are torn, in which only skin is torn, right? All the degrees, the grades, right? I'm not going to that traumatic PPH management because that's separate topic where the trauma to the perennial muscles or perineum is discussed, right? Trauma. So this is the PPH involved here is called as traumatic PPH. Traumatic PPH, and this is also a kind of primary PPH. So atonic and traumatic, you can consider this in primary PPH. Okay. Third thing is called as tissue PPH. Third thing we call it as tissue PPH. Ultrasonography is the you can say investigation of choice over here. Okay. Tissue PPH. Tissue PPH may be due to two causes. One is called as RPOC. What is RPOC? RPOC means retained products of conception. RPOC. Retained products of conception. Some remnants, right? RPOC. Or we can have something called as endometriosis. Endometriosis. Okay. So endometriosis and RPOC are the things, right? In RPOC, primary and secondary, both PPH are there, but endometriosis is predominantly a secondary PPH, right? It's a secondary PPH. So they ask you the question, what is the most common cause of secondary PPH? Most common cause of secondary PPH is basically RPOC, that is retained products of conception. Okay, then the fourth T basically is what we call as thrombotic disorders or thrombin defect, you can simply say thrombin defect. Thrombin defect, this is the fourth cause. What defects, of course, some bleeding disorders, coagulation disorders like DIC, you can say ITP, DIC. Okay, all of this, let's say on anticoagulants, a patient is on anticoagulants, right? Blood will not coagulate, it will bleed, obviously. Thrombin defects, tone, loss of tone, trauma. Okay, any trauma, perineal tears and all, tissue PPH due to RPOC or endometriosis or thrombin defects. Okay, these are the basic things which you have to know. So if I see the PPT, yes, okay. So tone, told you uterine atony, most common cause loss of tone of the uterus is basically uterine atony. Issue is due to retained placenta or clots, which we broadly said that retained products of conception. This is the most common cause of secondary PPH. Endometriosis also is a secondary PPH. Endometriosis is also secondary PPH. Don't worry. Then trauma. So RPOC. Endometriosis, secondary PPH, I told you. So genital tract tears, uterine rupture, these all traumatic conditions which you can say are coming under traumatic PPH. Thrombin, coagulopathies. Coagulopathies, I told you, DIC, ITP, bleeding disorders, anything. Okay. Coagulation disorders, bleeding disorders, I'm not going into hematology. Four T's are clear. Risk factors. Risk factors of PPH. Basically, remember, whenever there is over distension, there is a risk of PPH. Of course, if there is over distension, the chances of uterine rupture is more, right? So, over distension, let us write the risk factors. The first one, over distension. Over distension of uterus. Remember, antepartum hemorrhage basically predisposes a person to postpartum hemorrhage. Antepartum hemorrhage, APH. Third thing, medical disorders. Okay, what are some common medical disorders you know? Liver disorders, then hypertension, diabetes mellitus, comorbidities I can write, or let's say just I'm writing DM, HTN. Okay, these are medical disorders. This predispose a person to PPH, right? Or you can say coagulation disorders, obviously. Coagulation disorders, medical disorders, coagulation disorders, instrumental deliveries, whichever chances of inflicting trauma to that. So instrumental delivery. Okay, all of these are risk factors. Preeclampsia, I told you. Coagulopathies, operative delivery, placenta accreta spectrum. There is a spectrum, right? PAS, placenta accreta spectrum. Previous PPH increases the risk of subsequent PPH. Prolonged or augmented labor, chorioamniotis, macrosomia. Macrosomia is an important risk factor, right? Twins and polyhydramnios. Polyhydramnios, macrosomia, and twins are basically distending the uterus more. If there is more distension of uterus, whenever there is expulsion, there is the delivery, basically the chances of bleeding is more. Because you can imagine, right? If the distension is more, then the chances of bleeding will be more after release of that particular area of space, right? Okay. Over distended uterus, all of this. All of these are risk factors. Okay, these are clear. These are particularly clear. Okay, before prevention, let us not go into that. Let me first discuss with you. We'll discuss management of atonic PPH. How can you manage the atonic PPH? Recognition, quantification. You can just okay, okay. Immediate management. I am here. First response. Whenever there is a PPH, the first thing is that you can't manage alone. Please call for help. Teamwork is basically the utmost important in case of PPH. Mobilize the PPH team. What are the things you have to take? Airway. You have to secure the airway, oxygen, and two large bore IV lines. Okay, two large bore IV lines are important. Fluid resuscitation and blood cross matching, because there is a huge blood loss. You will need blood transfusion. Uterine massage and oxytocin. We'll see now, right? Okay, I'm discussing the drugs. These are the drugs which you commonly use. These are the drugs. Let me discuss it in my style. Okay, so I am telling what is the management. So whenever a person has atonic PPH, basically we'll see the atonic PPH in this module. The management starts with bimanual uterine compressions, right? The management starts with, right. So I was telling that for managing atonic type of PPH, the first thing that you have to do is bimanual uterine compressions. Bimanual uterine compressions. Okay, or massage. Or massage. That then you have to analyze the position of the patient and you have to keep the head low, right? Head low. Head low position is a basic step of management to improve the venous return. Since the patient is losing much blood of us, right? You have to maintain the cardiac output temporarily. So head low position is important thing. Since the patient is losing electrolytes along with blood, fluid resuscitation is very important. Fluid resuscitation. Okay, ringer lactate will give the patient ringer lactate, right? And to control the bleeding, what is the most common drug that you give to control internal type of bleeding? We basically use Tranexa. Tranexa is basically tranexamic acid, right? So tranexamic acid. Tranexamic acid. And tranexamic acid, according to guidelines, is given 1 gram IV. 1 gram IV. Okay, this is the guideline. Okay, and other drugs are added if atonicity persisting atonicity. You have to add other drugs. Bimanual uterine compressions are important. Head low position, then fluid resuscitation, and tranexamic acid is important. The drug of choice is basically, what is the drug of choice? What do you think? Injection oxytocin, of course. Injection oxytocin. Injection oxytocin is a drug of choice. Okay, this is the most important line that you have to do. And what is the doses? 20 international unit. 20 international unit. I told you, right, that you have to keep ready the two large bore catheters, right? IV cannulas, not catheters, IV cannulas. So you have to administer two large bore IV lines. Okay, fluid resuscitation and all of this thing. Here, oxytocin 1 international IM, IV or IV bolus, it is given or infusion. I'm writing 20 international units, right? 20 international units plus RL you give IV plus RL IV. Basically, we give two large bulk IV lines are there, right? So two drugs, not two drugs. The saline and the oxytocin is going simultaneously hand in hand, right? So this is the drug of choice. Okay, we have other drugs. We have other drugs as well, right? So in other drugs, my tab is hanging a bit, so don't mind. Okay. So in other drugs, what do you want to give? Okay, we can give misoprostol, tab misoprostol. Misoprostol. Okay, we can give tab misoprostol, and misoprostol, the dose is uh, 800 to 1000 microgram. 800 to 1000 mcg, that is microgram. Okay, you can give this. Okay, and you can give it sublingually as per the requirement, sublingually, or you can give subrectal also. Subrectal also. Okay, so tab misoprostol is there. What other drug you can give? Ergot derivatives like methergine. Methergine is not preferred by many, but since it is ergot derivatives, the side effects are more. But I am writing ergot derivatives. Ergot derivatives. Okay, ergot derivatives, and ergot derivatives you can give depending upon your preferences. IM. Okay, you can give IM or you can give IV, whatever you prefer. Ergot derivatives may be used, but very important, very commonly used drug and preferred drug, I can say preferred drug is basically tab, carboprost, not tab, carboprost. Carboprost is basically prostaglandin analog, right? PGF2 alpha acting on the PGF2 alpha receptor, and the dose is very important, very commonly asked. 250. 250. What is 250 microgram? And what route? IV, sorry, IM route. Okay, not IV, IM route. Okay, 250 microgram IM every 15 minutes. Just a minute. Okay, so my tab is hanging a bit and don't I particularly know the condition causes. Okay, 250 microgram IM route. Okay, and you have to give every 10 to 15 minutes. Every 15 minutes you can write. And if you give in this dose, maximum of 2 gram you can give. Okay, up to maximum 2 grams, maximum 8 times. Max 8 times. Max 8 times. Okay, you can multiply and give the dose. Okay, and these drugs, this ergot derivatives and carboprost, please don't use in asthmatic patients, right? You can use misoprostol. It's safe in asthmatics. In asthmatics, the misoprostol is safe. Okay, done. Okay, this is the pharmacological management of atonic PPH. Okay, you can see here ergometrin. Ergometrin is basically this I was telling. This is ergot derivative. Ergot derivative, and 0.2 milligram IM you can give, right? Carboprost, I told you, 250 microgram IM route every 15 minutes, right? Maximum 2 milligram. Avoid in asthmatics, okay? In asthmatics, please avoid carboprost. You can give the misoprostol. Misoprostol 800 to 1000 microgram per rectal sublingual, per rectal or sublingual. And tranexamic acid, I told you, 1 gram IV over 10 minutes within 3 hours. Okay, you have to give within 3 hours. Please do keep this within 3 hours condition in mind, over 10 minutes, and 1 gram IV. So doses are important over here. Please do remember the doses. And now we move to non-pharmacological management. Okay, the last non-pharmacological management is basically our interventional management. If medical management, first you have to manage medically. Okay, first you have to manage medically. If the medical management fails, then you have to try the second line interventions. Second line interventions. And the second line interventions, first by Buckley catheter. Okay, you have a catheter, you can use condom, you can use Foley's, you can use anything, right? Buckley's balloon, okay. UBT, that is uterine balloon tamponade. The first thing is UBT, uterine balloon tamponade. Please do see the picture. This is UBT. Okay, you take a inflating thing like balloon, right? This is Buckley's balloon, and inflate it. This will block the outlet and prevent the bleeding temporarily. UBT. Okay, so uterine balloon tamponade. If uterine balloon tamponade fails, if UBT, just a minute. Okay, so if uterine balloon tamponade fails, UBT, you tried UBT. First, you tried pharmacological management, right? Then you tried UBT. Let's say this UBT fails, then you do UAE, not United States of Emirates, right? Or whatever it is, not that Arabian states. UAE in option gyne is basically uterine artery embolization. Okay, you do embolization of uterine artery. Uterine artery ligation, internal ligation, uterine artery embolization is available. Okay, if it is available, you have to do it. Uterine artery embolization. Okay, UAE. If the patient is hemodynamically stable and this all treatment UBT UAE fails, okay, if the patient is hemodynamically stable, you have to make the patient stable if you are using surgical management. In surgical management, you have something called exploratory laparotomy. This is the surgical management, exploratory laparotomy. In exploratory laparotomy, you have to do devascularization. Since bleeding, you have to find the source of bleeding. You have to devascularize it. Devascularization. Remember a concept. Whenever you are doing devascularization, you have to start from the smallest branch, right? So whenever you are doing devascularization for this purpose, you have to ligate the uterine artery first. Okay. Then you have to ligate the ovarian branch. Then you have to ligate the anterior division. Okay. This is called as serial or stepwise devascularization. Stepwise devascularization is the most important thing. And then you use, after devascularization, you can stitch it up with compression sutures. Compression sutures. And the most important compression suture which you commonly use, there are many compression suture. You can use Heyman compression suture. You can use CHO or CHO, whatever you say, suture. Okay, and the most famous suture which you commonly use is B-Lynch suture. B-Lynch. Okay, B-Lynch suture. This is the B-Lynch suture. It can come as a spotter. Okay, this type of suturing is basically B-Lynch suture. Okay, and this procedure here is uterine artery embolization, UAE or uterine artery embolization. Okay, all of these things are clear. Uterine artery embolization, Billin suture, done. Even if after this all treatment fails, the last option, all fail. If all fail, what is the last option you have? Some last option must be there, right? So last option is hysterectomy. Last option is hysterectomy, and you have to do subtotal hysterectomy. Okay, you have to leave behind cervix and do subtotal hysterectomy. And accordingly, in concomitant course, like along with this all bleeding control, everything. Okay, you have to correct the coagulopathy as well. If it is necessary, you have to correct the coagulopathy as well. It's a surgical. I told you, B-lin suture, uterine artery ligation and embolization, UAE, and peripartum hysterectomy if uncontrolled bleeding. So you have to save the life, right? Don't have to save the uterus. So you can just remove it if it is bleeding like anything, right? Peripartum hysterectomy, which is commonly subtotal hysterectomy, right? So these are the things. Massive transfusion coagulopathy. You have to balance RBC, FFP, plasma, platelets 1:1:1. You can give it. Monitor HP, platelets, INR, fibrinogen. According to the coagulopathy, have to be corrected. Correct all the complications of bleeding like hypocalcemia, acidosis, hypothermia. Have to control these all conditions. Okay, that is important. Monitor vitals and urine output. After resuscitation, what you have to care. Okay, ICU care if it is needed. Thromboprophylaxis have to given once bleeding is controlled. Okay, because correction of coagulopathy, again I am telling, is very important. Counseling, documentation, morbidity review. Key take home messages, what we read is basically, first of all, is the definition according to WHO is 500, in the cesarean section 1000, in hysterectomy 1500, and in case of this ACOG, it is 1000. We saw 4 T's, okay, 4 T's. Then we saw the risk factors: diabetes mellitus, just the coagulopathies, anything, risk factors. After the risk factors, we saw the management of atonic PPH, and atonic PPH drug of choice is oxytocin, oxytocin 20 international units. After oxytocin, you can try other drugs like carboprostate is a wonderful drug, and carboprostate 250 microgram given IM over you can say 15 minutes. Okay, over 15 minutes, and maximum to 2 gram. And after carboprost, you can try, or you can try some ergot derivatives like ergometrin is there, methyl surgery is there, methogen is there, everything. Okay, and these are the major things which are there. And if pharmacological treatment fail, first of all you have to do is UBT. Okay, uterine balloon tamponade or balloon. Okay, you can use a Bakri catheter for that. And if it fails, then uterine artery embolization. If uterine artery embolization fails and the patient is hemodynamically stable, the patient is hemodynamically stable, you can do exploratory laparotomy, and in exploratory laparotomy you can do a stepwise devascularization. Okay, a stepwise devascularization, and you can just ligate the arteries over there. Okay, devascularization, could cauterize or ligate anything. Okay, so that all the things which, and I told you that concomitantly, or you can say concurrently, you have to correct the coagulopathy along with the bleeding, right? So I told you all, resuscitation is important, risk factors are important. Okay, and compression suture, I told you, Billin suture is most commonly used. Okay, you can use Cho suture, you can use that Hemin suture, everything. Okay, so and if everything fails, last option we have is peripartum hysterectomy. Okay, that is a subtotal hysterectomy if uncontrolled bleeding is there. So that's all in today's session. I guess 30 minutes, and 30 minutes we discussed PPH. I hope you understood what is PPH, and these are the key take home messages which you want, you can take a screenshot. Okay, and I'm showing you the slides. These are the second line interventions: UBT, B-Lynch, uterine artery ligation, uterine artery embolization, peripartum hysterectomy. If you want, you can take a screenshot. This is the management protocol of this condition. Okay, these are the important things. and you can take the screenshot of risk factors, right? And etiology, the four T's: tone, trauma, tissue, thrombin. Okay, have to remember it: tone, trauma, tissue, and thrombin defect. Definition is very, very, very important, because if you don't know what it is, then what's the point of, like, okay? So that's all in today's session. That was postpartum hemorrhage. I have not gone into detail, just superficial things, but it is crisp and concise according to your exams, right? As well as in practical life. Thank you and good night.